and we're going to try this Facebook Live again. I wanted to talk to you about pelvic girdle pain because it's a topic that seems to come up really regularly. So pelvic girdle pain during pregnancy is specifically what I'm going to be talking about here today. Now, hopefully you got a chance to watch the first video that I recommended last week that we could talk about some of the mechanisms that are or are not behind pelvic girdle pain. But I've made a couple of notes here so I stay roughly on track, and we can talk about what is driving pelvic girdle pain, and of course, more importantly, what can we actually do about it? So without further ado, we'll jump in. Really, when we're talking about pregnancy-related pelvic girdle pain, we're talking about pain anywhere between the rib line and the gluteal fold. So it is quite an extensive area. And I think what we have to do is we have to balance out our perceptions, some of the mythology about pelvic girdle pain with, is it a mechanically driven issue? Is it a centrally driven issue? What's going on? I think one of the things to remember is, we mentioned this last week in the video, that as pregnancy progresses, there are a lot of weight changes. So the center of gravity changes. You're carrying a lot of extra weight in the front of the body. The breasts are getting bigger. The baby's obviously getting bigger, amniotic fluid, placenta, all the other things that are going on. But we also have to look at what's going on centrally. And before I go any further, can we talk about relaxin? Can we talk about poor old relaxin that gets blamed for everything? So if you do a lit search on relaxin and pelvic girdle pain, you will see there is no correlation between the level of relaxin and the severity of pelvic girdle pain. It does not make your ligaments, loose to the point of instability. Men have relaxin. We know that relaxin peaks week 12 to 16 in pregnancy, but most pelvic girdle pain is actually much later in the pregnancy. So let's stop blaming relaxin for everything, because it's not the driver for pelvic girdle pain. What we do know is that a lot of the tissues throughout the body in pregnancy do become quite sensitive. So probably driven by estrogen and progesterone to a degree, but we know that tissues are sensitized during pregnancy. So we want to keep that in mind as well. We also want to bear in mind the importance of the language that we're using when we're talking about pelvic girdle pain. It's really, I think, important that we stay away from words like stability and instability, out of alignment, out of place, different things like that. I think those are really damaging words because they conjure up a very fearful situation. And we're actually seeing now in the literature, in the research that's going on at the moment, that stress and lack of sleep and cortisol levels are more strongly linked to pelvic girdle pain maybe than a lot of the mechanical factors we've been talking about and blaming for a while. What else could be driving pain in around the pelvis? So I can refer back to my own clinical experience here, and over the years seeing women in pregnancy who've been referred by GPs or by OBGYNs for pregnancy-related pelvic girdle pain, and they were never examined. And I picked up at least one DVT, vulvar varicosities, hemorrhoids or piles. There are lots of different things that are happening in around the pelvis, potentially in pregnancy, that can cause pain in the pelvis. So blaming it all on pelvic girdle pain on a mechanical issue really, I think, is doing a lot of women a disservice. So for example, other things to think about that could be drivers of pain in the pelvis during pregnancy. Is it a UTI? We know that UTI incidence can go up during pregnancy. Could it be a fracture of the neck of the femur? And this is something worth thinking about, the transient osteoporosis of pregnancy. We talk about this in the course, of course, quite a bit. Could she actually have sustained a femoral neck fracture? And that's what's driving the pain. So knowing how to test and screen for that would be important. DVT, as I've mentioned. DVTs, particularly in that inguinal crease, we used to talk about Holman sign, but being familiar with Wells criteria, has she been immobile? Has she had recent surgery? different issues like that. With a DVT, you know, to have a look at the tissue, and oftentimes if it is a femoral DVT, we would see unilateral redness and heat and labial swelling. So pelvic girdle pain should not cause any of those issues. So if you see any of those issues, that is, you know, that's a medical emergency straight away into the hospital with her. Could it be the round ligament? You know, is the pain going from sit to stand? So really simple way to see if that's what it is just get her to support, you know, hands under the bump, going from sit to stand, and slowing the movement down, because those things can really trigger a little bit of a stretch on the round ligament, and that can cause quite a sharp pain in and around the symphysis pubis. So just to be aware of that. Piles, so, you know, hemorrhoids. We know that constipation is really, really common during pregnancy as well. We know that constipation is strongly linked to back pain in women anyway. But, you know, to have a look, if you are a women's health physio and you're doing an exam, you know, if you see these little bunches of grapes coming out of the anal opening here, making sure you're asking everybody about constipation, about what's going on, because the anal canal, once you are past this dentate line, this external part of the anal canal here, it's as sensitive as your mouth. It's sensitive to heat, to pain, to stretch, to temperature changes. So hemorrhoids can really be excruciatingly painful and tender, and they're very common during pregnancy. And of course, we want to deal with the pelvic floor dysfunction that can often accompany constipation as well. If there's any pain anywhere around the pelvis, if there's any sense of threat anywhere around the pelvis, the pelvic floor muscles can become quite overprotective, and that's something we're going to talk about a little bit as well. I'm just going to move this light a little bit because I think it's going to fall off if I don't. So, first question: how are you? How are you doing with this pregnancy? Gauge her stress levels. Ask her how she's sleeping. Of course, ask about constipation. Really important. We know that pelvic girdle pain is particularly common with second and subsequent pregnancies as well. So, you know, how is she coping with being pregnant and maybe dealing with other children at home as well? Important to ask as well. So, have you had back pain before? We know that, you know, previous incidents of back or pelvic pain can be very common with subsequent issues with it. So if you've had it before, what worked then? Can you do that again? Okay, just find out, you know, what the pattern is going on here. Asking what calms things down. When do you feel the pain the most? What do you do to relieve it? You know, and how can we kind of tap into the clues that those answers are going to give us for calming the system down? And then as we build a bit more resilience in the system, we are going to look at building the reserves up. More about that anon. So what calms things down? What aggravates your pain? What can we do to change those aggravating factors? So if it's going from sit to stand or moving around in bed is particularly aggravating for her pelvis, then those are things that we can definitely change. And I'm going to give you some suggestions for that as well. So calm things down, build things up, build resilience, build trust back into her body again. Your pelvis is strong. It's probably the strongest part of your body. Unless you've had major car trauma, major vehicular trauma, your pelvis is not unstable. It's not out of place, but it is sensitized. It's trying to protect you. Your brain and your pelvic floor muscles are trying to protect you the only way they know how, by going into this overprotective, overactive mode. And what we need to do is calm them down. They're sensitized, so we need to talk quietly and softly to them. We don't want to shout at them. We don't want to be aggressive with them. We want to calm them down. We want to look at rebalancing the autonomic system, and then we want to work on building resilience up around the center of the body, obviously, but predominantly building resilience in the brain. That's really where we're looking at as well. The brain rules everything else. If we're thinking about things from this central perspective, you might be familiar if you've come across the work of David Butler and Lorimer Moseley about SIMS and DIMS. And SIMS are safeties in me, and DIMS are dangers in me. And what we want to do when anybody has any kind of centrally driven pain, any pain at all, is we want to make sure that the SIMS are greater and stronger than your DIMS. So statements that you as a women's healthcare professional might use in these scenarios would be: your pelvis is stable, it's strong, it's sensitized, it's a little overprotective at the moment. But ultimately, you're giving the message that it's strong, it's robust, it's resilient. And what we're going to do is we're going to work with it to help it feel better. If you're using language like your pelvis is unstable, it's out of alignment, your lumbopelvic complex, your ilium is anterior rotated, your sacrum and your coccyx are side bent, that's very dangerous nociceptive language. Let's calm the nervous system down and work on building it up again. So if we are going to be operating from an evidence-based perspective, then we want to focus more on the central mechanisms rather than the mechanical mechanisms. If you saw the anatomy video I did here a couple of weeks ago, like the millimeters, 2 or 3 millimeters, is really all that's going to be happening in around your sacroiliac joint. What happens is everything gets a little bit ramped up and over anxious, particularly the pelvic floor muscles, and they want to act as guardians of your pelvis and guardians of your body. So we want to calm them down. We also want to look at what possibly are the pelvic floor muscles compensating for, particularly with that change of gravity that's happening, that increased anterior mass, the baby, the breast, the amniotic fluid, as we've talked about. If you were to get a 10-pound bowling ball and hold it out in front of you all day, every day, your muscles might not have the strength and the endurance to deal with that. So what we want to do is we want to calm things down, but we want to work on building up some of the supportive muscles around here. So we've talked about this a little bit before in the previous video as well. We want to think about what's happening with, spin it around here, glute max and glute med, because those are going to support this posterior aspect of the pelvis. We want to think about what is happening with the abdominal muscles. Like, look at the stretch that these abs are going to be on to support the baby. So rectus is attaching into your symphysis pubis. The adductors are attaching all along here, along the ischiopubic ramus. And then, of course, the pelvic floor is supporting from underneath. So we want fit, strong muscles that have a good range of movement, a good range of motion, and functional levels of strength and fitness to get us through pregnancy, to get us through labor and delivery, and then a speedy recovery postnatally as well. So I'm not saying that we don't work these muscles. We absolutely do. But we want to look at, you never want to start trying to build strength on a muscle that's already overactive and a bit freaked out. Calm it down first, re-establish range of motion, and then we're going to work on building up the pelvic floor, which are very small muscles at the end of the day. And we're going to look at what are the bigger global muscles doing to help give that strength, that sense of strength, of confidence in movement as well. So we are looking at a strong, stable, but maybe a little bit of a sensitive pelvis. Really important when we start talking about the impact of stress and sleeplessness and centrally driven, brain-driven influences on pain, that we don't come across with the message that this is all in your head, and that you just need to, catch yourself on and it'll all be fine. You're just making it up. Pain is very real. It's really real. But we know that stress and lack of sleep and issues like that and beliefs about instability can really turn the volume up on that pain. So we want to calm down, control our controllables, calm down those drivers, and then work on building up resilience. Can asymmetry aggravate sensitized tissue? Of course it can. Absolutely. If I have a sensitive pelvis, let's just say I haven't got great glute max or glute med strength, and I'm pregnant again, and I'm carrying a toddler on one hip, and I'm trying to do everything else with my other hand, and work is maybe a bit crazy, I'm not sleeping, maybe there are other stressors going on as well. Of course, all of those things are going to feed in, but the asymmetry is a mechanical factor that can certainly increase sensitivity and pain output in around the pelvis. So I'm not saying that mechanics have nothing to do with it, the opposite. but they're part of the picture. They're not the whole picture. How does the instability belief impact or influence pelvic floor muscles? If your pelvic floor muscles are receiving messages that you are in danger because your pelvis is unstable and is going to fall apart, then they are going to react in the only way they know how, by tightening up and holding on for dear life. Now, that's particularly true of the superficial pelvic floor muscles. Your deeper pelvic floor muscles, so the levator ani muscles that I talked about in the video last week, they will be more driven to kick in if a lot of the supportive muscles, the big global muscles like your glutes, if they're not doing their job properly, then sometimes the deeper pelvic floor muscles and the pelvic wall muscles, so muscles like piriformis, obturator internus, they can sometimes try and kick in if the glutes aren't pulling their share of the load as well. So if those muscles are constantly in this sort of a mindset, I want you to think about what's happening to the nerves and the blood vessels that are moving in through the pelvis at this time. Nerves don't like being compressed. Muscles and nerves, neither of them enjoy having their blood flow reduced as well. You can get a lot of inflammation soup then building up in around the pelvic floor muscles, and it becomes this self-fulfilling prophecy. So what we want to do is, again, calm the muscles down, persuade them that it's safe for them to let go, let a bit of blood flow through, release some of the pressure on the nerves, restore faith in movement, and start building the system back up again. Okay, so again, to kind of paraphrase the Canadian physio Greg Lehman, we want to calm things down. So they're in an overprotective state. So it's like, it's okay, you can let go, it's safe. And then we want to build things up. But we want to figure out is, are the pelvic floor muscles compensating for another link in the chain? So could it be the glutes? Could it be the abdominals? And oftentimes it's the pelvic floor muscles and the adductors. So I want you to imagine that your pelvis is unstable. What instinctively is one of the first things you do? It's like you squeeze your knees together, you cross your legs, don't you? Because you want to try and keep everything together. So we want to persuade the adductors and the pelvic floor muscles to let go. And we want to work on building up a sense of strength and support and stability in around the pelvis. Okay. One other thing just to bear in mind as well is that not every pregnancy is a happy event. And I think sometimes we can rush to a conclusion that it's totally joyous, and it might not be for that person. So, how are you feeling about this pregnancy? How are you feeling about the pelvic girdle pain? How is it affecting you? How are you feeling about labor and delivery? How are things going to be afterwards? Have you thought about that at all, or how are you feeling about that? Because that sense of trauma, maybe they had a bad obstetric experience in a previous pregnancy, that can all feed into pelvic girdle pain as well. So it is about asking the questions, about staying within your scope and, having a team that you can refer out to as well. But acknowledging that, again, central is probably more important than mechanical when it comes to pelvic girdle pain. All right. So what can we do about it? This is the important part, isn't it? We want to think about when and where and how is the pain occurring. A sensitive pelvis may not like single leg stance. So standing to put on a pair of jeans or yoga pants, standing on one foot while you're trying to wiggle your foot into the shoe, getting in and out of the car. Your pelvis might not like that. And that kind of makes sense, because if you think about the weight of, the baby, all that anterior line stuff going on here, and then you're standing on one leg, you're depending really, aren't you, on glute max or glute med, the adductors and the pelvic floor to hold everything in place. Now, if they're already trying to hold on for dear life, they're probably not going to enjoy single leg stance, and they're going to send more distress signals to the brain, and that's going to respond with pain to get your attention. So simple things like avoiding single leg stance as much as is possible. When you're getting into the car, put your hips in first and then move the legs in. Sitting down to put on a pair of yoga pants or your shoes or socks or different things like that. Going from sit to stand. So that's probably, we do that, about 9,000 times a day. So to look at some of the patterning around that and what you can do to change it. Your brain loves novel input. It loves new things. That gets its attention. If it's anticipating pain, it gets stuck in a rut, and it always hurts when I do this. And it's almost like it's pre-programmed. But if you can do it slightly differently, it's going to, oh, that's interesting. Maybe this is a better way to do it. Maybe I don't have to output pain, because remember, pain is always an output from your brain, always. Okay, so the messages come in from the nerves. They're interpreted in the brain. Is this a threat? Should I be scared? If yes, we're going to send out pain. If not, okay, we don't need to send out any pain here. So do remember that as well. So sit to stand. What is happening with the head and the neck and the jaw? The muscles at the base of your skull have a huge amount of proprioceptive nerve activity. Just really in that suboccipital region alone, those neck extensors there. So if you are constantly in that sort of, chin out position, there's a lot of compression going on with those proprioceptive messenger centers there. So working on maybe a little bit of deep neck flexor strength could be a good idea as well. Remembering as well the other balance mechanisms, we want to think about your inner ears as well. Are they clenching their jaws? If they're clenching their jaws and their mouth is closed, what is happening in terms of their airways? Is air actually getting in and out? If they're breath holding when they're going from sit to stand, where is all that pressure? It's going down onto an already beleaguered pelvic floor as well. So teaching somebody to exhale with the effort, to try and keep the back of their neck nice and long, maybe, lips together but teeth apart, breathing in and out through their nose, okay, and keeping the air moving. So your pelvis isn't unstable, but certain things can give you a sense of instability. So again, head and neck would be one of them. But the other big area of proprioceptive input to our brain and our balance centers, we've got our eyes, we've got our inner ears, we've got those suboccipital muscles there at the base of our skull, is our feet. What happens if towards the end of pregnancy you can't see your feet? That can also be a little bit disorienting for your brain's balance mechanisms, which means the pelvic floor and everything around the pelvis is going to be holding on for dear life as well. So what can we do to improve proprioceptive input into the feet? Can we do a little bit of foot and ankle mobility? Can we do a little bit of rolling? I love these foam golf practice balls. You could use spiky balls. They're too much for me. These are great. They're soft. They're cheap as chips on our good friends at Amazon. And just to start rolling out the feet and the ankles so that when you do go from sit to stand, you can have maybe one foot slightly in front of the other, so that when you stand up, you've got a larger base of support, which means that you're going to feel more stable, and you're breathing, which means you're not pushing down against a pelvic floor that's doing this, and it can make it a little bit easier. Other things to think about going from sit to stand with pelvic girdle pain. Are they pushing down with their hands on the arms of a chair? And again, breath holding, pushing down with your hands, drives all that pressure down to the pelvic floor. It's already trying to hold everything together, it thinks, and now you're pushing down on me even more. It's going to freak out even more. So what we want to do is make sure that the glutes are able to do their job. So if going from sit to stand or stand to sit is problematic, we might break that down into smaller pieces and look at, we could look at changing the base of support, making it wider, making it narrower, moving the hips into internal rotation, external rotation, playing around with it a little bit like that. but we might want to make sure that we are adding in some functional glute strengthening work into the mix as well. So mini squats, maybe with the TheraBand around the outside of the knees to make sure that the glutes, med and max, and the deep hip rotators are working harmoniously with the breath and the pelvic floor. So that'll be something to think about. Yeah, so changing the feet, where are the hands, making sure the glutes are working rather than breath holding in the pelvic floor muscles. Your pelvis is not unstable, but what's making you feel unstable? The next thing to think about with pelvic girdle pain during pregnancy is, can you feel the difference between your pelvic floor muscles being on and off? So what we want to think about is, there's a couple of different ways we can do this. You can just sit up nice and tall, and actually that's another thing that you can do. You can change the height of the chair that you're sitting in if transferring from sit to stand is a problem. So put an extra cushion or two underneath you. You can change the length of time that you're sitting as well. Don't sit for too long, because when you're sitting, your entire body weight is squishing down on the pelvic floor muscles. So again, what is that doing to blood flow and to nerve compression in around the area as well? So setting a timer on your phone every 15 minutes that you're getting up and moving around a little bit, but also the position that you're sitting in too. Are you sitting slumped back onto your sacrum and your coccyx, or are you sitting up onto your ischial tuberosities and offloading a little bit of the pelvic floor as well? So just getting somebody to practice kind of, shifting around side to side, feeling the ischial tuberosities, cluing them into their external anal sphincter, I think is a good way to really focus on female pelvic floor muscle activity, and that will be borne out by a lot of the literature as well. Can they feel what happens when they close their anus and lift up and in? Can they feel what happens when they relax? Can they feel what happens when they gently bear down towards the chair? So as if they're trying to lay an egg. Now, you don't want to do a massive Valsalva, obviously, towards the end of pregnancy for obvious reasons, but a gentle, as if they're trying to pass a little bit of gas and then relax again. Can they feel what happens there? If they reach back and put their hand onto their own coccyx externally, can they feel when they close and lift their anus that the coccyx moves up and forward towards the pubic symphysis? And as they let go, it moves back down again. Maybe doing something like the stuck drawer technique, if you have manual therapy skills, could be really useful. So I'll pop a link to that video in the comments below here once I get this finished. Just to kind of tune into the movement of that part of your body. So the coccyx is a really important indicator of what's going on with the pelvic floor muscles. And it's something that you can teach a woman to tune into herself. So she uses her best biofeedback tools to develop that bit of self-efficacy and agency over her own body. What else can you change? So the height of the chair, the length of time sitting, and the position that you're sitting in. Bed mobility is another distressing part of pelvic girdle pain. So when they want to change sides, towards the end of pregnancy, it's like you just get comfortable in one position, then you feel they have to change over into another position. So rolling under rather than rolling over, keeping the knees together, sometimes tying a scarf or a belt or a piece of TheraBand around the outside of the knees, so you can really engage the deep hip rotators, glute med and glute max, instead of overly gripping the pelvic floor and the adductors, which can trigger a little bit of pain output. That can be helpful as well. Putting a pillow under the bump when you're lying on your side can also stop a little bit of tissue drag on the front of the pelvis. When you are getting into bed to lie down, don't do like a reverse sit-up to lie down. So don't sit on the edge of the bed and then lower yourself back down like an eccentric crunch or a sit-up. That's a lot of strain on an already stretched anterior abdominal wall musculature. So sitting on the edge of the bed and teaching somebody how to do and go into side lying, first of all, keeping the knees together, again, maybe with something around the outside of the knees to get a little bit of pelvic hip rotator engagement going on there, calm down the adductors in the pelvic floor, and then keeping the feet together, even squeezing your heels together rather than squeezing your knees together. That's a really useful little trick to get the deep hip rotators kicking in instead of the adductors. What else do we need to do? So we've talked about sleep. Sleep is really important because when the baby is on the outside world, sleep will be minimized, but we know that decreased sleep is linked to increased pain output from the brain. Stress levels and bowel health, all strongly linked to back pain generally in women, but we know that they are all linked to cortisol output, one of our major stress hormones. And there's some really exciting research going on here in Ireland, actually, at the UCC microbiome unit down in Cork. If you're on the advanced pregnancy wellness course and you've seen the interview that I've done with Dr. Sinead Dufour, she talks about the research that she's involved with, looking at cortisol, inflammation, sleep, and pelvic girdle pain. So what we're looking to do is calm down that autonomic nervous system, decrease cortisol output, and one of the best ways that we can do that is movement and exercise. So exercise really is this magic bullet that we can use to address pelvic girdle pain on all these different levels. Does manual therapy have a role? Absolutely. Manual therapy can be a great way to calm things down, and then it's your gateway towards confidence in movement. Manual therapy by itself is only going to have a very short-term temporary effect, and you are not putting the pelvis back in place. You are not correcting alignment. You're really not doing any of those things. What you're doing is you're calming down the nervous system enough to allow confidence in movement again. So manual therapy is great around the adductors, posterior pelvic floor to increase proprioception, to focus on down training, but it's always a gateway drug towards movement. What else? So pelvic girdle pain is more common in second and subsequent pregnancies. So again, just to factor in what are the other stressors that she's dealing with. Does she have less time for herself now this pregnancy? Because the first pregnancy, it's just you and the bump, and you hopefully have some time to focus on self-care and exercise. When you are pregnant with a toddler at home, it's a completely different scenario. Particularly if there are other stressors, work, partner, money, coronavirus shutdowns, all those different things, all those different stressors do appear to be really powerful influencers of pelvic girdle pain. The belt. So should we use a belt for pelvic girdle pain? And I'm kind of, I'm in two minds about this. I think if we can solve the pain drivers without depending on an external support system, great. But if not, if a belt gets you out of pain, I say go for it. So a really simple test to do is to get a scarf or a towel and to wrap it around your hips at greater trochanter level. And what you do is you just get her to give a little bit of compression. Can you see that? I'm going to try and hold that up here. Give a little bit of compression there. So just around the levels of your greater trochanters. And one of two things will happen. Either she will go, that feels brilliant, I'm never taking it off again. Or she'll go, oh my God, that makes it feel so much worse. It's usually a fairly dramatic reaction one way or the other. So why might that be? If you get a dramatic, that feels great when I put the belt on, what is that telling you? It is telling you that the pelvic floor muscles probably are saying they would like a little bit more external support from glute med and glute max and maybe the lower abs to offload some of their workload. If it's making it worse, you're compressing an already stressed out, overactive, compressed muscle, and it doesn't care for that at all. So if a support belt works, that's great. You can't use it when you're sitting down. You can only really use it when you're up and about. It's a little bit of a faff to get it in the right position, but if it gets you out of pain, that's brilliant. An exercise strategy will then keep you out of pain. If the belt makes you worse, you need to really focus on down training, on calming down the autonomic output, on relaxing the pelvic floor muscles, and then building up resilience in movement again. So that's where the manual therapy might be quite helpful for the adductors, for the pelvic floor, for the coccyx, using something like the stuck drawer technique. Don't depend on the belt to solve all the problems. There actually isn't great evidence to support the use of belts, but for some women, they can really just be such a strong gateway out of pain that I think it is probably worth a try. If you're doing everything else and you feel like they just need a little something extra, then try that compression test with a scarf or a towel, see how that feels. Do bear in mind that there's still a lot of misinformation out there about pelvic girdle pain in both lay people but also in the medical community. Too many women are still being told by their medical providers that their pelvis is unstable, that pain is to be expected, that it will go away after the pregnancy ends, that there's nothing really can be done about it. And that's just nonsense and unacceptable in this day and age. We know that 20% of women have persistent pelvic girdle pain after pregnancy. So it's not just pregnancy, it's not just a normal part of pregnancy. And we really need to look at what could be driving that pain in around the pelvis. So hopefully you have some guidelines on that today. We're really looking at rebalancing the autonomic system as well, calming down the output of those stress hormones, building confident, fearless resilience in movement. I suppose at the end of the day, it's about teaching women to trust their bodies, to trust their pelvis, and to hopefully have a good ally in you, in their pregnancy wellness clinician, who can, talk to them with confidence that they're doing so from an evidence-based perspective, that this is what the literature supports, that we look at the stressors, we do look at some of the mechanical factors that can irritate or annoy a sensitive pelvis, but your pelvis is strong, it's stable, it's just become a little bit overprotective. And what we need to do is we need to calm it down, we need to reassure it, and then we need to build it up and make it stronger. So if you had, for example, a very sensitive child at home, would you yell and shout and scream at them if you wanted them to do something? If you were dealing with a scared animal, a dog or a horse or something like that, if you go in yelling and super aggressive, you're only going to freak them out even more. And your lizard brain, your amygdala, that primal part of your brain, very much is a bit like that. Do we want to send the brain into fight or flight or freeze, or do we want to calm it down, reassure it, and then build it back up again? So teaching women how to trust their bodies, to trust their pelvis is strong, stable, and resilient, but we just need to calm it down a little bit. That's really the message that we have going forward. Again, if you're in the advanced pregnancy course, maybe go back and have a look at the interview that I did with Sinead Dufour. There's lots of information around there. And really to think about exercise strategies that are going to focus initially, probably best on a sensitive pelvis to do with 2 feet on the ground. But the idea is that we want to always make the exercise be functional for her lifestyle. So for me, all roads lead to function. Brain, breath, pelvic floor, calm nervous system. All right. Hopefully that was helpful. If you have any questions, just pop them into the comments below and I will get to them as soon as I can. Have a great rest of the day and bye for now.